So this is a little bit of a naughtier one. I was really excited to write this paper because, as you know, I spend a lot of my time thinking about these police behavioral health partnerships. It wasn't too long ago that in Washtenaw County in Michigan, I was called by our deputy sheriff, and he said, we have a little problem here. We have a guy with a firearm who's held his mother hostage. We think he's got a mental health issue. Do you mind coming to the scene and helping our officers? And it was in COVID. I hadn't left the house. I got picked up in an unidentified black limo, and my son saw me. I said, bye, kids. I'll be back for dinner. And my son said, I'm sure you work for the CIA, Mom. I'm sure you work for the CIA. I was like, no, I didn't want to tell him. I'm going to this major event. It turned out to be a 36-hour standoff. The parents were fine. Everybody lived. The young man was fine. He did get taken into custody. And then I went for an after-action review with my fellows. I said, oh, come, we're going to go to this thing. 100 officers were there. I thought I was just like this little person who got called. I didn't even know why I was called. And they went, 7:02, he holds the firearm. 7:05, he takes the mom hostage. 7:07, Dr. Pinals arrives on the scene. I was like, oh my God. What did I do? I just said multiple times, why now? Because they said, we want to do this. We want to do this intervention. We want to turn off the lights. We want to blow the door down. Drones were flying. Seriously, this was a serious incident. I mean, it gives me chills to think about it. They had CMH, the community mental health, was working with the SWAT team and helping, and they were doing what they did, but I think everybody was, it was a panic moment. And it's because I do a lot of work with the sheriff. They know me. But really, my question was constantly thinking about what do we do in a psychiatric unit when somebody's dysregulated? We just wait. We wait. We wait. Patience, patience, patience. And really, what we did was we gathered facts. The CMH workers went to talk to the mom who had been released from this young man. The mom got history. We learned about his behavioral health history. We learned what's helped him and what's not helped him in the past. There were probably substances on board. It was an awful situation. And in the town, just down this, in another community, the same day, the person was shot and killed. So the fact that nobody died in that incident was unbelievable given the circumstances. So again, thanks to everybody. You guys saw this. I don't have to do this again. And you saw this. So what this is about is the idea that we have moved from the murder of George Floyd and defund police to this idea of who is going to respond when and how do they do it well, right? To maximize positive outcomes and minimize negative outcomes. That's the goal. So this paper is called Lending Hands. It's really about how do we lend hands utilizing the expertise of various first responders to think about complex situations. So when you see the paper, you're going to see I start with scenarios that derive from my work in the emergency department and in some of the crisis scenes. Not that dramatic example, because obviously that's an extreme example. You've got a hostage situation, you've got a firearm. I think everybody knows that that's not going to be your local social worker that's going to go alone to that scene. But what about this? The adult male with schizophrenia who's increasingly psychotic, damages all sorts of property, destroys the kitchen, throwing cans in the kitchen, hearing intense voices. He thought that the walls were sending him signals. He thought there was somebody trapped in the house. And so he was trying to find that person and save him. And he becomes paranoid about his parents. His parents can't get him to calm down. Is that going to be a behavioral health response, or is that going to be a law enforcement response or an EMS response? What about the depressed older man whose daughter went to take the car keys from him because she was worried about him driving because he had early dementia, and he runs into the house and gets a firearm? Who's that going to be? What about the sister who calls crying hysterically because her sister has suicidal thoughts and she thinks she's using drugs in the house, and having a neighbor whose son just died of an overdose? This happens, as you all know. So what about another scenario, local community mental health calls for law enforcement backup because they have a client who's on AOT, who's well known to them, and he won't open the door. And they're concerned about his safety. They said, we need help getting the door open. And the law enforcement says, we don't do that anymore. We have a disengagement policy now. You guys have to deal with that yourselves. A day later, the SWAT team ended up getting involved. City attorneys had advised the law enforcement in the local community to not get involved because there was too much liability if they got involved, and said it was a CMH matter, community mental health. These are real scenarios that I have encountered, and probably you have too. So who responds? Well, that caused me, as I wrote this paper, to think a little bit about some stories that Brian told me a while ago about this idea of men in white coats. I was like, where does that come from, that phrase, men in white coats? And what does it mean? When we hear about men in white coats, we don't think good things, right? We think coming to take you away. And that's actually what, if you look at the old literature from the 1800s, it's the men in white coats from the state hospitals were coming to take you away to a, so that's not good either. We don't want the social workers in white coats, and you heard again from Rowan. So what do we do about this? Because there's this problematic representation about getting people in care who are in these acute, distressing situations, and we don't want it to be frightening. So now we've shifted to blue uniforms. Maybe they have a CIT badge because they're supposed to be a friendlier blue uniform. But really the scary thing is like what's going to happen. And so how do we think about responders, not just as coercive, but also as available and lending hands in a supportive way, but also understanding that the reality of behavioral health is messy and that sometimes coercion is going to be what you need to do. Any one of those 4 scenarios that I described before are going to probably involve somebody going somewhere that they don't necessarily want to go, but maybe there's a way to engage them and help them understand through dialogue, procedural justice, and all sorts of lofty things, a better way to do it so that they understand what's happening and why. So we really need these new models to demonstrate this evolution in responding empathically and in the least restrictive manner possible. Now, you all know about intercept 0 and the sequential intercept map. That's what we're talking about, this intercept 0-1 interface that I think people are really having a hard time actually talking about because it's so sensitive. I teach this in my law class, and I show them a video of a man with paranoid schizophrenia with a knife. And they're, you know, I have these great University of Michigan law students. They're like, there's no way that there should be a police response. I said, well, really? Like, do you really want the unarmed social worker to go in and really just try and deal with a knife when we know knives cause more police injuries than guns? Like, that's not realistic. So how do we do this, and how do we do this equitably and really dialogue about who's going to go where so that we don't have the disproportionate police-involved shooting that we know the intersectionality of serious mental illness and being Black become a dangerous combination for being a victim of police officer shootings. So we really have to think about this evolving role. We're doing some really cool work in Michigan. We have this behavioral health emergency partnership training where we're trying to bring the 3 legs of the stool together so that everybody's getting the same basic training, and then they go off and develop their skills, and they can yell at each other in the room to talk about why things aren't working and fix the problems and partner together. We have to think about what Dan Abreu from PRA wrote in the, as he wrote about, he and his colleagues wrote about Intercept 0, about police having 2 roles in our society. Some of them are called peace officers, but they do have this warrior public safety role, but also this role of guardian. That is the role statutorily and historically, and it has twisted, and we need to think about what that is going to look like and in what circumstances so that we get better outcomes. Again, as I said, Black persons with mental illness are more likely to be victims of police officer shootings. The impact of disproportionate police contact among marginalized communities and its toll on anxiety, depression, and trauma is something that cannot be ignored. So that mere police presence can be triggering. And so what is that going to mean if we have situations where we need police to respond? How do we build in better relations. Non-fatal encounters with police are associated with poor mental health outcomes. So police stopping you and being, and yet, as Brian wanted me to highlight, we know that gun violence, including firearm-related homicide, increased 35% in the last, from 2019 to 2020, with black males ages 15 to 34, particularly at risk for victimization, and 20 times more likely to be victims of gun homicide. So you've got the problem of marginalized communities getting heavily policed, and then this heavy policing creating bad mental health outcomes, and so we have like totem pole issues. And so we really need to think about what does community engagement look like in a way that doesn't lead to inequity. There was a paper I wrote with my colleague a couple years ago for NASMHPD talking about the inequities of how community engagement of community policing has been, with two theories of ignore the difficult neighborhoods and let them fend for themselves and leave them without the supports, or over police them. Like neither one is going to be the right answer. So we have to think about the myriad intersecting issues and consider the intention how we roll out crisis services. Now, with EMS, they're also evolving. It's not just us that's evolving. From 1966, when President Johnson recommended standardizing emergency training for rescue personnel in our 911 system, in 1969, the EMT ambulance curriculum was published with, by the way, magnitudes higher dollars than what we're receiving, even though we're thinking, if you look at it in 2022 years of dollars and what they're worth. Of course, medical conditions are broader than psychiatric, but still. So a lot of money went into this. Yeah, it equaled $2 billion today of what was funded for the Emergency Medical Services Act. And so, we know that data shows that ambulance transports are increasingly involved in mental health. And so how do we think about what that looks like? Other data that's really important is that on the ground, workers responding to emergencies are not without risk. Fatal work injuries of law enforcement, including their own suicides, by the way, roadway incidents, accidental shootings are something that's tracked. And EMS responding to increased behavioral health calls. So our workers doing these responses, are going to be at their own risks. And there's going to be issues that we're going to have to strategize around with our responders to mitigate those risks. And so really building out these partnerships between 988 and 911. We know from data from Pew that PSAPs may lack the resources and training to handle behavioral health crisis. EMS is already on the scene. Academic reviews and in the gray literature show numerous types of models: co-response, parallel response, coordinated response, multidisciplinary responses, cahoots response, talks about cahoots, municipal, county, and state level oversight don't always connect. In fact, many jurisdictions that I've gotten involved with, there's a lot of disconnect between what's happening locally, county, and state, also with adults versus kids and how that's going to play out. So a lot of work needs to be done around really trying to intentionally build this partnership with the idea of one lending hand to the other and thinking about what are the joint policies. I can't tell you how many communities I've gone to where you say, do you have policies that address what your EMS is doing and your behavioral health responder? And it's like, no, we built our own policy. Well, I know from a recent incident where a CIT officer came and EMS came and behavioral health mobile crisis came, it was a mess on the scene. Nobody knew who was supposed to do what. There was fighting amongst the responders, and this poor woman who was in the car with her kids, suicidal, kind of was at the mercy of these system dynamics. We can't let that happen. So we need policies for on-scene responses, coordinating roles and responsibilities, safety protocols. I know when I've done ride-alongs, the police have made me wear bulletproof vests, ensuring response that is least restrictive but does not abandon the need. There's also case law that's relevant to the space. I'm not going to get into it, but there's a couple of cases looking at people using substances and what can be criminalized constitutionally and what can't be. Behavior related to substances can be. So for example, where you decriminalize certain substances like we've done in Ann Arbor, and in other states. It doesn't mean that if somebody's disorderly because of methamphetamine, they can't be arrested for disorderly conduct. And when I was running forensic services in Massachusetts, how many times did we have people in for driving under the influence? Well, it turned out they were bipolar and they weren't really under the influence of alcohol, but they came in through our forensic process. And so you can, we are still going to see people coming into the criminal system, and we're seeing more and more people coming in through forensic doors with psychosis related to substances, and yet our forensic system isn't well equipped to address the substance use. Police have certain standards about objective reasonableness for when force can be used, and the ADA has been called into question about whether it applies to an arrest situation. The Supreme Court has not weighed in on that yet. So this idea, too, of this disengagement protocol that is happening, and I've seen it in media reports now in several different states, hands-off policies as in the aftermath of the defund police creates other things, and like I talk about with our recipient rights folks, there can be abuse and there can be neglect of vulnerable populations, right? Overuse of force is abuse. Neglect is a different kind of problem for vulnerable populations. And so we really need to think about that spot where we're intervening appropriately and not leaving people with serious mental illness to barricade themselves in homes and be on their own without the proper supports to get them into the help they need. So the Americans with Disabilities Act, EMTALA, all will come into play as we think about this. Transport is another important area. Costs associated with transporting people with mental illness by law enforcement, according to the Treatment Advocacy Center, involve over 20% of officer time in 2017. So in the jurisdictions where I've practiced, this becomes a constant issue of how do you transport, what are the different places where transport becomes critical? From the home to the crisis stabilization unit. Well, if it's not going to an emergency department, insurance won't cover it, is one thing I hear all the time. And so you can't get an ambulance to transport. So what's your option? Is that police as the transport? Well, we don't want to use handcuffs, but our policy is that we have to use handcuffs. So can we procure, like some states have done, alternative transport mechanisms so that we're providing a better mechanism to move somebody from home to a new type of crisis center or a living room situation or wherever the transport is going to be able to be. Then there's the transport between hospitals. In some of our communities, we barely have enough ambulance drivers to transport people that are medically fragile because that workforce is really depleted as well. So then that's more ED boarding, waiting for transport to arrive. But does every psychiatrist, like I'm very close to our state medical director for EMS, and we talk about this all the time. He's like, does every medical patient really need an ambulance? I don't think so. If they have a broken leg and they just need to go to a trauma center, you know, we can stabilize the leg. So why does every mental health patient need an ambulance? You know, historically, it's because of the fear that the person's going to run away and they need to be restrained during transport. That's pretty much, again, the messy side of psychiatric care and how it works. But is that really necessary in every situation? Clearly not. Now, if it's voluntary, you can put a cab voucher out there or an Uber. We've done that before, and I've done that from the emergency departments. But that takes a lot of comfort when I'm the psychiatrist discharging the patient from the emergency department. That takes a lot of comfort for me, who's worried about liability, to be able to send somebody on their own who just came to an emergency department to get to a crisis stabilization center. So I think there's a lot to be thinking about around transport. And again, some states have really done some exciting work along these lines. Mental Health America raised concerns about youth in handcuffs during mental health transport, looking at how do we think about voluntary, how do we build in that voluntary transport mechanism? And so there is a CMS benefit, non-emergency medical transport, but again, it has to be non-emergency. And so what do we do with this in this space where it's non-emergency, but it's kind of urgent and not a routine medical appointment? right? That's the problem. We have this kind of no man's land issue around psychiatric transport. And so again, states are examining who might transport and how it could be funded in lieu of law enforcement or even ambulance when that's feasible. What about medical clearance and no refusal policies in this lending hands kind of space? We have this idea that, you know, this whole idea under EMTALA is that the person has to be medically stable for transfer, right? And you can't dump the patient, you can't street the patient if they're not medically stable. So a lot of states are doing work around what does that mean to be medically stable for transfer. In Michigan, for example, we've developed something called the MySmart protocol using the SMART form, which I think other states have picked up on. Now, I think it started with some research out of California, and it's a pretty simple acronym where you check off the major medical things that you need to think about. And what I keep saying to both our medical health plans and our psychiatric carve-out health plan medical directors is what we want is, what we know is that people with serious mental illness tend to get they tend to have their medical conditions under-evaluated, right, for most medical care, except when it's time to send them to a psychiatric hospital when we're over-ordering labs because the psychiatric hospital wants to kind of be guaranteed that they won't be having somebody on the psychiatric unit who's got too many medical problems for them to be able to manage. So we have this problem, and so what I think of as these protocols are, again, trying to thread the needle so we're not ignoring medical conditions, because I can tell you, I remember one patient that I admitted to a state hospital who was all confused, and when the nurses went to do a physical exam, it turned out he had a portacath. Turned out, as we learned about him, he was a guy who needed dialysis, who hadn't gotten his dialysis, and so he was all confused, but nobody in the emergency department had bothered to do a physical examination to see that he literally had a portacath and had a serious medical condition. They said he's confused and we think he's got schizophrenia. So we know we have this problem of under-evaluating medical needs and over-evaluating, and so these protocols can help us and also help meet those EMTALA standards so that we know that people are stable for transfer. But at the same time, how stable do people need to be psychiatrically? So we have to, I think we're going to be seeing a lot more over time about what EMTALA means for psychiatric care and getting people transferred and why there's hospitals rejecting, you know, we saw during COVID positivity was a reason to reject people from psychiatric hospitalization. I don't think there was any state that totally solved that problem, and yet we were leaving people on scatter beds, on medical units, and the like. So medically stable for transfer and psychiatrically stable for transfer, and then no refusals with warm handoffs and no wrong door approaches. So there's a lot of work to be done, and again, this I think, you know, as we look at the continuum of care, hospitalization is still a very important part of that continuum of care. And the acute hospitalizations and rejection rates for the people that we serve in public behavioral health are profound. And so how do we address that? How do we look at no refusal policies? How do we build in contracts to ensure that if you're going to be paid for serving the behavioral health population, you're not going to be violating EMTALA in terms of rejecting people who need that level of care. And so we have a lot of things to do around that. And again, that's where the lending hands and the partnership, you've got EMS, you've got law enforcement, you've got hospitals, everyone needs to be kind of rowing in the same direction. So just going back to this idea of out-of-hospital care, and I spoke about this before in the prior talk, but really what we're seeing is things that we should be thinking about. You know, I just went to a recent EMS presentation, and they started talking about their SICE-START protocol, which is what they're doing in pediatric behavioral health crises or traumatic events, where they do a rapid triage assessment of who needs more psychiatric support. This is an EMS protocol. I thought it was super interesting. I hadn't been familiar with it until I heard about this. So EMS, which they know their data is that they're responding to more and more behavioral health emergencies, they're building out protocols to deal with behavioral health, just like they have, they're very protocol oriented. They have a medical authority who writes the policies kind of for the state or the county or the local. And the medical authority says, if you see this level of agitation, you use this dose of medication. It's very, for the EMTs and the paramedics, it's very protocol based. And so now they're building in protocols around psychiatric issues and when kids may be involved with traumatic events or showing some kind of behavioral health crisis. So, are we aware of that? Are we connecting? Do we know what those protocols are? Does the public behavioral health system weigh in on those protocols, or is that EMS driven? And again, how do we lend hands and not build silos to think about that? Then there's also the idea of virtual assessments and, again, treatment initiation early on. I mean, it would be an amazing day where you can actually start to have that therapeutic alliance with the individual while they're actually dealing with some of the issues in the best way you can. Now, somebody who's throwing dishes around the kitchen because they hear voices in the walls, you would say, well, we can't really do anything then. And I would say I disagree, because I think that's a great moment to try and we see from data from the Netherlands and others looking at open dialogue, really starting to build that conversation, the family support, the education right at the get-go with what we're dealing with should be part of those out-of-hospital care protocols. Okay. The workforce needs, again, enhanced recruitment in this space of first responders. We need to build quality of first responders. We need to give them the nurturing and resilience. This follows the theme that I was telling you before. In the first responder space with both EMS, law enforcement, and mobile crisis, we need to give them a sense of connection to the larger systems to help decrease their own burnout and frustration. Because if we're going to have them respond to crises and in the field where it's pretty rough, and I don't know how many of you have done a ride-along, I would really suggest you get a ride-along experience, because whether it's with your mobile team or with law enforcement, it's pretty eye-opening. You really want to be able to give them the tools that they need where they're in that out-of-hospital environment, thinking on their feet, but needing to think together for who responds when, and not call those who don't need to respond so they can be saved to respond to things where they are necessary. And so that's really going to be, I think, the challenge as we move forward. So just to highlight a few things, again, these medical clearance protocols, less restrictive transportation options, no wrong door, are needed to divert people in crisis from criminal justice and help overcome barriers to accessing care following a mobile crisis response. This out-of-hospital treatment can provide rapid access to care interventions and reduce the need of costly hospitalizations, again, post-crisis. And to proactively address the workforce space in the crisis response is really important to nurture and the current and future workers who are going to be exposed themselves to all types of traumatic circumstances and see all sorts of things kind of in the raw. And I think that's just something that we have to pay attention to in terms of providing that support and that emotional support, because if you've talked to anyone who's gone to a scene and had to cut down somebody who's hanging or had to deal with the filth of somebody who's hoarding, these are not easy jobs. And it's really going to be important that we nurture people. And it's important to be real about it. That's why I use real language and real stories. Law enforcement and its partners will play a vital role in crisis response, but it's necessary that these police partners receive the tools and training, because there does need to be reform. And they know that. We've learned some really painful societal lessons, and we're not there yet. So that's going to be something important, but to walk away from that isn't going to help solve the needs of our populations either. We have to think about, just like in the firearms debate, you may be a gun lover or a gun hater, but if we don't kind of work together to help reduce suicides, we're not going to get where we need to get from a public health perspective. So again, you can be pro or con on any issue politically. Your politics isn't what I'm here to talk about. I'm here to talk about getting better outcomes for more people and fewer negative outcomes for more people. Mobile crisis responses are now messy. Cool, exciting, but complex. And so we have to do some sorting. We don't have real data that, I mean, we have data that shows this program was cool and this program diverted from arrest. We used to collect our mobile crisis data, our co-responder data to say how many people were diverted from arrest in Massachusetts. And most of them were, which was fantastic. But the little secret behind that was many of those people still had criminal complaints to deal with. They just weren't taken into custody. So they could still end up in the forensic system because now they've got a default, because now they're psychiatrically hospitalized and they don't show up for their court date. And if you're a failure to appear state for bail, you've got a failure to appear on your record. So we have to kind of think about the numerous models of interdisciplinary response to try and get the outcomes that we want. Legal regulation, including case law, liability concerns. These are new frontiers. What is going to be the liability of a mobile crisis responder when something goes awry? They will not have the same protections of Fourth Amendment search and seizure potentially that police have. And so what is that going to look like? And what standard is that going to fall under? I think there's a field of, I don't know if there's attorneys in the room. My best friends are attorneys, so it's no, but there is a field out there to be thinking about that. And so we want to think about that, with intention around what are our policies support and how do we train people around that, and how do we continue to push the Americans with Disabilities Act, even though the Supreme Court hasn't weighed in on that, but really on at least on that arrest situation. How do we really think about how people with disabilities are managed in the community in these out-of-hospital contexts to get that to be integrated and on par with other people? And so, at the risk of repeating myself, get that sustainable, expandable funding, coordinate, think about these multidisciplinary points, think about all these things that I've been talking about, leverage technology, fund research. We need more research. We have a lot of good ideas. We need research that looks not just at outcomes, but outcomes for each population so we understand disparities and inequities. And so that means we have to enhance data collection around all of these interventions as we roll them out. You all know that it's really hard once you get a pet project out there and a community loves their response model to pull back and say, is it actually doing the work that we want it to do? And how are you evaluating data besides qualitative good feeling? Really, are we getting the outcomes that we want? So data collection, data collection, data collection. And again, just want to thank you for your attention and hope you learned a few things and happy to take any questions.
Good morning. My name is Lisa Burgess. I'm from Maryland. I'm going to ask what may be a challenging question. You had a stats on black homicide, and I'm just curious as to the nature of the population that committed the crime. Whether it was the black person killing another black person, was police killing the black person.
So that data, I think, if I'm remembering the citation that you're talking about, was not a police-specific study. It was looking at, and it didn't look at perpetrator race, as I recall. It was really looking at who are victims of homicide that we have to think about. I would have to look back at that the study to be 100% certain. But
thank you so much. It wasn't to put you on the spot.
Oh no.
But since it's a safe space, I've been told that many times since yesterday. I just think that with the potential to talk about that problem of why we have black-on-black crime in the first place, I think it's very important as behavioral health clinicians. So in the media, they report it, and they say, "Why are you complaining about police brutality when you kill each other?" And so the entire history of that may not be, messaged. And I think that's extremely important to understand the history, right? So the message in the United States is that you're not worthy. And so as brains, we hear the same and we learn the same rule. It's like 2 + 2 is 4, Well, the person to my left, who may not look at me, he'll remember that 2 plus 2 is 4, and I'll remember that 2 plus 2 is 4. So if the person beside me learns that a black person's not worthy, then I may learn the same thing. And so it's something that I don't hear a lot in our conversation, but I think it's extremely important that we start sharing that information.
I think that's so important. I think that I really applaud your getting up and speaking about that. You know, I think that is part of the reason why I want to be intentional about talking about the problems that we have broadly around the impact of societal views, over-policing, the trauma, you know, all of these things, and trying to look at data across populations to understand how to make responses that are, you know, equitable, and that we're not seeing disproportionate impact on the black community, or certainly not disparaging or thinking that black persons are not, you know, what difference does it make? Because of course it makes a difference. So I really appreciate that you raised that. Thank you.
I have a question about, in situations where you have 911, 988 working together, in some cases they've come up with a triage using a certain type of matrix where 1 through 4, 1 is high risk, 4 is low risk, 1 police go out, 4 behavioral health go out. Have you seen these type of triage tools, and are there any that you might recommend more than others?
Yeah, I don't have any that I would specifically recommend more than others. I think this is an evolving field. I think the other thing is that you can go out to a situation that seems low risk and be on site, and it can actually be high risk, or it can be made high risk with escalation instead of de-escalation. And so the one thing I have to say for talking to a lot of my first responder folks is it is a rapidly evolving landscape. And so the thing is, if you don't call the response in right, you know, if you call it the way you see it from the phone triage and the dispatch response, and again, very protocol driven, you have to be ready and able to have a lending hand come if the situation changes, because it can shift dramatically in a moment. And you know, the dispatch teams really need to understand, you know, what data to collect. You know, I've done a lot of CIT training with dispatch. You know, their jobs are so hard, and we don't think about how traumatizing those jobs are, where they're hearing screaming in the background, frantic people calling, and they're trying to make the best decision that they can make. But we have to recognize that if you don't have those protocols of how you get backup, so let's say you send a mobile crisis team, that could be your best correct based on data level of response. On the scene, new data emerges, a random stranger, you know, incites the incident. You got to have those partners at the ready.
Yeah, so what we've seen in some situations is where it seems to be working well is that where a mistake is made, where a 911 team goes out and it seems clear they don't really need, 911 sends police out, and it's clear the police aren't needed, the police back out and then they call behavioral health. And we've seen the same where behavioral health goes out, they realize that there's a problem, they back out and get call 911 and get the police involved. What is needed there is trust and relationship. Would you say something about what may be helpful in developing that trust and developing that relationship between the 911 and 988?
Yeah, I think we're going to need, I mean, I think cross-training is a great way. One of the challenges is with training with EMS and training with police, a lot of it is now online. You know, obviously CIT is a mechanism, but it's 40 hours, but it's only 40 hours. And so you need to have, you know, scenario-based training dialogue. You need to have community problem solving, where you have what in the police world they call it after action reviews. Things in medicine we call morbidity and mortality reviews, where you look at an incident and you come together and say, why did this not go the way we wanted it to? Or what was so great? Why did this go so well? What did we learn from this great event? So the more you can have that kind of dialogue to problem solve and improve your policies, the better.
Thanks, Deb, for a wonderful talk as always. I have kind of a 30,000-foot question. One of the things that we have done in South Carolina over the past several years is really trying to increase our relationship with law enforcement. We spend a lot of time with putting mental health professionals in law enforcement areas. We have more ride-alongs. There's lots of people there that we're doing. And that's where a lot of focus for our mobile crisis is gone. The challenge that I see is there's a bunch of pushback on the other side that usually comes from often the community, sometimes the mental health community, of why would you spend so much time going there? And the conversation from our side tends to be, unfortunately, that's where the mental health patients are these days. So unless you really do develop that relationship with law enforcement, you're going to be behind the 8 ball. So I just want to get your opinion on where do you see that relationship going? How should we think about its evolution, especially as we're moving kind of into this 988 world?
Yeah, I mean, I think that's a great question. And I do think, you know, the community discourse is, couldn't we have, and it's like my law students, couldn't we have a world where we don't need law enforcement at all? And why are you building that relationship? I think those, you know, it goes back to the old SAMHSA's community conversations framework, where you really are trying to talk about how to solve problems. And in this paper, for example, I used scenarios to set the stage for thinking about this, because when you really think about actual cases, you know, people are concerned that if 988 leads to a coercive response, well, the data is great to show that most of the time we can engage people to get to yes and get to the problem solving themselves, because that's why they called. But if somebody calls and says, I just took an overdose of 100 pills, are you going to not rescue them? Of course you're going to rescue them. That's the whole point of suicide prevention. And so that means you're going to have to bring out an EMS response. Whether the community needs EMS and ambulance to be that much, I mean, EMS and police to be that lockstep joined at the hip, I think there's other things to think about there. So it's really, I think, trying to engage the community. But right now, it's a really tough time because, you know, I think there is really a sense of, why do we need police? And, you know, maybe someday we won't. Maybe there will be a different element out there. But right now, these are our tools. So I think it's really having those community conversations.
Thank you. So I want to thank Dr. Burgess from Maryland, the commissioner from Maryland, and thank Dr. Rogers, commissioner from South Carolina, for your questions. So what I forgot to say is when you get up to the microphone, please introduce yourselves. So that was my fault, I'm sorry. What we really wanted to do this morning was to see if we could stress Dr. Pinals. So we have an assignment for you. We want you to do 2 back-to-back presentations, and we're going to monitor you to see if you're able to stand up during that whole time. So, and I think she did a magnificent job, so thank you.